Right, welcome and thank you for joining. My name is Ashley Lusick, and I am a health educator for community health at Atlantic Health System. Today's webinar, Head and Neck Cancer Risk Factors and Prevention, is presented by Dr. Eric Cohen. Before we begin, I do have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or chat for comments. We will try and get through all questions at the end of this presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with groups available in person or virtually. For more information about these groups and other resources, or for additional dates and times, please call 1-844-472-8499. I am now going to turn it over to Dr. Cohen.
Thank you for the kind introduction. I'm going to share my screen here. Okay. So as Ashley said, I'm going to discuss today head and neck cancer screening and prevention in honor of Head and Neck Cancer Awareness Month. And it's an honor to speak today. First, I wanted to give everyone an overview of head and neck cancer, which is a somewhat large topic. So there are many head and neck tumor sites. Head and neck cancer is sort of a misnomer in a way. It's refers to tumors of various specific sites, including the oral cavity or mouth, the larynx or pharynx, which is often referred to as throat cancer, salivary gland tumors, thyroid tumors, and others. Another way of thinking about it is by different head and neck tumor types. So the most common type of cancer in the mouth and throat is something called squamous cell carcinoma, and that makes up the large majority of cancers in this area. Whereas in other sites, such as salivary gland and thyroid, it's a completely different set of tumor types. This talk is primarily going to focus on head and neck squamous cell carcinoma. Just to review the anatomy, the oral cavity refers to the mouth, so the front part of the tongue, the roof of the mouth, etc. The pharynx is another word for the throat. The nasopharynx is the upper part above the roof of the mouth. The oropharynx is the part that you can see in the back of the throat, where the tonsils are in the back of the tongue. The hypopharynx is the lower part of the throat, getting down towards the opening of the swallowing passage or the esophagus, and the larynx is the voice box. Historically, treatment for head and neck tumors has been primarily by surgery to remove the tumors, although over the past few decades, multimodality treatment has evolved, including the use of radiation treatment and chemotherapy, either in addition to surgery or in some cases in place of surgery, with what has come to be known as organ preservation treatment for non-surgical management. Management of tumors in the head and neck are important because of the functions that these structures are involved with, including airway and breathing, swallowing function, speech, smell and taste, vision, facial expression, and cosmetic appearance. Over the years, we've put more emphasis on the functional outcome of cancer treatment, including better reconstructive techniques. In some cases, we can use less invasive surgical techniques, and in other cases, we can use non-surgical treatment to avoid surgery that would cause problems with function afterwards. We've also learned the importance of overall patient well-being, emotional and spiritual support, survivorship support, and the importance of non-medical factors in quality of life and prognosis. Despite the advances in head and neck cancer treatment, Ideally, it would be prevented before these cancers even begin. So a key to that is understanding the causes of head and neck cancer and how we can reduce risk and potentially detect cancers early on rather than when they are more advanced. I think the most well-known risk factor for head and neck cancer development is cigarette smoking, which is a well-known risk factor for cancers in many areas. Perhaps less well-known is the risk of alcohol consumption, smokeless tobacco, something called betel nut or betel quid, which is a type of product that's chewed primarily in South Asia, but is a major risk factor for oral cancer. Cigar and pipe smoking, while less common, are still risk factors for cancer development. Uh, Marijuana smoking has been associated with risk, as well as poor oral hygiene in general. This slide just demonstrates the importance of alcohol consumption and smoking as a risk factor. And in fact, more importantly, the combination of risk factors can lead to significantly elevated risks of head and neck cancer development. So if you look on this somewhat complicated graph, the risk of head and neck cancer development increases with the amount of alcohol containing drinks per week. And on this line, you can see that the risk of head and neck cancer development progressively increases with higher rates of smoking. But the combination of drinking alcohol and smoking cigarettes over towards the right here, you can see that there's a much more than additive risk with people who are both heavy alcohol drinkers and heavy smokers, have an almost 40-fold increased risk of developing head and neck cancer than those who are non-drinkers and non-smokers. Over the past few decades, there has been an overall decrease in the incidence of head and neck squamous cell carcinoma. And most likely this is a result of decreased smoking rates among the population. But one site in particular, the oropharynx, so that's the area with the tonsil and the back of the tongue area, has actually shown an increase in the risk of or incidence of cancer over that same time frame. So obviously there's something different at play than smoking if it's decreasing in every other site, but increasing in that one particular site. So this is a trend that had been noted in many areas of the world, with a 2 to 3-fold increase incidence of oropharynx cancer noted in Sweden and other areas. And this was actually found to be related to an increase in the incidence of human papillomavirus related cancers, or HPV. A relatively small percentage of cancers in the oropharynx were associated with HPV, whereas in the 2000s, the majority of cancers were found to be related to HPV. And this is predominantly one particular type of HPV that is actually overlaps with cancer, with HPV related cancers in other parts of the body, such as the cervix. The way that this can happen is that when someone has a infection with a high risk type of HPV, the virus particles uh, can get brought into the cells that line the mouth or throat. The DNA or genes from the virus itself can get integrated into the DNA of the chromosomes of the actual cell, and there are some proteins that can be formed based on these genes known as E6 and E7 that can interfere with the normal cell cycle, the way that cells normally divide, that can lead to cell transformation and formation of cancer. A landmark paper in the 2000s had identified high-risk sexual behavior as a risk factor for developing oropharynx cancer, and this is largely due to HPV infection. So people who had many sexual partners had a significantly elevated risk for developing oropharynx cancer, and patients who had evidence of HPV infection in the mouth had a very high risk of cancer compared to the general population, and those that had um, evidence in the blood of exposure, so antibodies against HPV, also had a very high risk of had oropharynx cancer development compared to those who did not have such exposure. Currently, roughly 3/4 of oropharynx cancers in the United States are attributable to the HPV virus. And in fact, the number of HPV-associated oropharynx cancers has actually surpassed the number of cervical cancers in the US, which is another HPV-related cancer. It can affect women, but disproportionately affects men. One of the interesting facts is that there can be a very long lag time from infection to development of cancer. Typically, can be several or more decades, which is different than in cervical cancer, where the lag time is much shorter. Only certain strains of the HPV virus are cancer causing. I mentioned earlier the HPV 16 is the most common, and this overlaps with the same types of HPV virus that cause cancers at other body sites, such as the cancer anus and other genital sites. The magnitude of risk is also significant. There was one relatively large study that was done in Europe that looked for evidence of HPV infection based on antibodies in the blood. Now, this is not a test that's clinically available, but for the purposes of this study, they were able to detect evidence of exposure by antibodies in the blood in people with oropharynx cancer in more than a third of patients prior to their diagnosis, where only a very small percentage of patients who did not develop oropharynx cancer, which showed an odds ratio, or an increase in a likelihood of developing oropharynx cancer of 274 times more likely. And in fact, of people who had evidence of antibodies to the proteins from the HPV virus in their blood, approximately 7% of females that went on to develop cancer, and 23% of males went on to develop cancer, which is actually quite a high risk. There is some good news in that HPV-associated oropharynx cancer has a much better prognosis than smoking or alcohol-associated oropharynx cancer, with a much lower risk of death and cancer recurrence than with non-HPV related cancers, and also in other areas such as in the oral cavity or in the larynx, where HPV is not an important factor. There is no difference in outcome, whether that's HPV positive or HPV negative. So oropharynx cancer, so in the tonsil or the base of tongue area, oropharynx cancer associated with HPV has a much lower risk. Unfortunately, there's really no currently clinically available blood test or imaging tests to detect head and neck cancer, so there's no mammogram equivalent. There are also no routinely performed cytology procedures, such as a pap smear for early detection of cervical cancer. That really doesn't. There's no similar procedure for oral cavity cancers. Oral cancers are often preceded by an identifiable precancerous lesion, so there is some opportunity for early detection of precancerous lesions. Similarly, vocal cord cancers can also be preceded by a premalignant lesion, whereas unfortunately in other areas, such as in the oropharynx, cancers are rarely preceded by an identifiable premalignant cancer. Since the oral cavity is relatively easy to examine, there is some opportunity for screening, and the dental community actually plays a very important role in screening for oral cancer, since many or most people visit their dentist regularly, and if there are any identifiable visible abnormalities or symptomatic lesions, they can facilitate the appropriate evaluation and biopsy to detect premalignant lesions. And if these are removed, that can prevent the development of invasive cancer. When we're talking about the pharynx and the larynx, they are much more difficult to visualize, and often specialized equipment and specific experience is needed for complete examinations of those areas. So screening is much more difficult. Early detection is another aspect of head and neck cancer uh, that is vitally important. So one aspect is having a high index of suspicion. So that means that when people have a history of smoking, a history of chewing tobacco use, a history of alcohol use, things that are known risk factors for head and neck cancer, uh, we have to be aware of the elevated risk of cancer development, so that if people have persistent symptoms such as hoarseness or voice changes, sore throat, pain or painful or difficulty with swallowing, ear pain, the presence of a neck lump or a neck mass, particularly a painless neck mass, are all potential symptoms of head and neck cancer. And certainly, if these types of symptoms are persistent or don't respond to the usual therapy, then one should consider the possibility and refer a patient for the appropriate evaluation to look for these things. Now, HPV related cancers presents a little bit of a dilemma, in that most of the people who develop those cancers don't uh, don't have the typical risk factors, and patients themselves and healthcare professionals often don't consider the possibility of head and neck cancer development in these patients because of the lack of other risk factors. But that's something that perhaps should change in the future. In terms of head and neck cancer prevention, since this is typically related to some type of environmental exposure, there's an opportunity for risk reduction. So, such things as smoking avoidance or smoking cessation, reduction or elimination of alcohol consumption, avoiding chewing tobacco or betel nut chewing, and promotion of good oral hygiene are all important aspects of risk reduction. The magnitude of reduction of risk is actually quite large. So this slide demonstrates the impact of smoking cessation on head and neck cancer risk reduction. So compared to a baseline at when uh, when someone has not stopped smoking, over the course of time, the relative risk of head and neck cancer development progressively decreases, and 20 or more years after stopping smoking, the risk of head and neck cancer development is reduced by more than 80%. So it's not 100% reduction, but certainly it's a quite a big reduction in the risk. There is also the potential impact of vaccination, particularly for HPV associated head and neck cancers. Since this is of a viral etiology, and it has the same high risk types of HPV as other cancers, such as cervical cancer, which have previously developed and approved vaccines, there is the opportunity potentially for prevention of HPV infection, and therefore prevention of HPV associated cancer. Importantly, these have to be given prior to exposure in order for them to be effective. So there are FDA approved HPV vaccines. Initially, there were two vaccines that were developed that were approved for girls and boys for the prevention of things such as cervical cancer, genital warts, and anal cancer. There was a new version of the vaccine called Gardasil 9 that included additional types of HPV, high-risk HPV viruses that was approved in 2014 for young males and females. The next year, it was expanded to older teenage and young adult males. In 2018, that FDA approval was expanded to men and women up to the age of 45, and this was primarily for the prevention of cervical cancer and other anogenital sites. But in 2020, the FDA approval was expanded to include prevention of oropharynx and other head and neck cancers that are caused by HPV. This slide just summarizes the Gardasil 9 for the different HPV types that it covers for, and the different types of cancers, genital warts, and other indications. So interestingly, the FDA approval for the Gardasil 9 vaccine for prevention of head and neck cancer was not given based on demonstration of preventing HPV-related oropharynx cancer, in part because there is no easily identifiable premalignant lesion, such as is the case for cervical cancer, and there's such a long lag time of many decades from the exposure to HPV to the development of cancer that it would take many decades to prove that the vaccine was successful in preventing cancer. So they actually accepted surrogate measures as evidence for protection. Part of this was the demonstration of the efficacy at the other sites that it was initially approved for, the effectiveness in preventing HPV oral infections, which has been shown, and also in those same patients of the suggestion of herd immunity in decreasing oral HPV infection. So what this means is that if a certain percentage of people have received the vaccine, that it confers immunity to other people who have not been infected by the HPV, other people who have not been vaccinated, because there's less HPV virus circulating, and therefore they are protected on the basis of other people being vaccinated. Historically, the vaccination rate for HPV is not as high as would be ideal. Initially, many girls would receive it, but a very small percentage of boys initially received the HPV vaccine. The ACIP, which is the advisory group that gives opinions on and advice on recommending vaccines to various groups, in December 2011 began recommending routine vaccination of both boys and girls by the age of 11 or 12. And this goes back to what I was mentioning earlier about vaccination being given before exposure to the HPV virus. This slide just demonstrates a study that was done of a statistical model of HPV vaccination, at least demonstrating the potential additional benefit of vaccinating both girls and boys compared to just girls alone, where in cancers occurring in men, if girls only are vaccinated, there was some reduction in the risk. But if boys and girls were both vaccinated, that there's a potential additional 65% reduction in the males developing cancer later on. Similarly, for females developing cancer, if both girls and boys were both vaccinated, there was about a 40% further reduction in cancer occurrence in females compared to if only the girls were vaccinated. So if both girls and boys are vaccinated, there is the potential for significantly more reduction in HPV-related cancer formation later in life. Surveys of immunization status across the country have shown that the majority of girls and boys in the teenage years have received at least one dose of the HPV virus, but only about half are fully vaccinated, at least as of 2018. So there's certainly room for improvement here. So in future opportunities, at least with respect to HPV vaccination, continued increase in HPV immunization rates among adolescents, I think has the potential to significantly decrease the occurrence of oropharynx cancer, but probably won't be seen for several decades. Another area of opportunity is increasing the HPV immunization rates among adults. So the vaccination rate for young men, 19 to 26, was only about 13% in 2016. Now, I mentioned earlier that the HPV vaccine is approved up until the age of 45 in both men and women. So not everybody will be exposed to the cancer-causing HPV virus during adolescence. So there's still the potential opportunity to prevent exposure to specific types of HPV with the vaccine, even later in life. So it's still something that is worth receiving to reduce the risk of developing oropharynx cancer. Finally, improving the education of the public regarding the HPV virus and infection and risk of oropharynx cancer is important because I've seen in my practice that many people, patients, family members were unaware of the risk of HPV virus in causing oropharynx cancer. So I think if more people were aware of this potential association and risk, that may lead to the increase in vaccination rates. So I thank you for the opportunity to give this presentation, and I'd be happy to answer any questions.
You can send an email to communityhealth@atlantichealth.org or call 1-844-472-8499. And I believe that concludes tonight's webinar, and I hope everybody has a great night.